The bones of the skeletal system come together or articulate at joints. Joints are classified into 4 major categories: fibrous, cartilaginous, bony, and synovial. In fibrous joints, such as the sutures of the skull, collagen fibers extend from one bone and integrate into another, binding adjacent bones together and keeping them from moving. Cartilaginous joints join 2 bones together with cartilage, such as the joining of the ribs to the sternum. Bony joints, such as those found in the sacrum and coccyx, occur during the normal aging process, when 2 bones that were previously separate fuse together. In synovial joints, such as the knee, a special fibrous joint capsule provides a sac-like pad surrounding the joint that is filled with fluid. Synovial fluid constantly bathes the joint, reducing friction as the 2 bones move. Synovial joints can be classified by their structure. Pivot joints and ball and socket joints allow for movement in many directions. Hinge joints and gliding joints allow bones to move in only one direction. Saddle joints and condyloid joints, such as those joining the thumbs to the metacarpals, allow bones to move in 2 directions.
So, as you've probably already observed within your own body, the bones of the human body work together to create a structural scaffolding to protect the internal organs and to facilitate movement. And as we can see in our image, every bone in the body articulates with at least one other bone, with the hyoid bone, which is floating up around the neck around here, being the only exception. Articulation, which is the joining together of 2 bone structures, is what makes movement possible. And the point of articulation between 2 bones is called a joint. Joints are classified according to the range of motion they exhibit and the types of tissue that holds the bone together. So when classifying joints according to the types of tissues holding the articulating bones together, we can describe 3 distinct types of joints. And these are the synovial joint, the fibrous joint, and the cartilaginous joint. And we're going to begin by looking at the synovial joint. And synovial joints are also called true joints. But what makes a joint a true joint? Let's have a look at some of the requirements below. So a true joint must have a discontinuous connection or separation between the bones, called a joint space. The articular surfaces of the joint must be covered in hyaline cartilage. It must have a closed joint capsule and therefore a joint cavity within, filled with synovial fluid. And most importantly, it must have ligaments and muscles that act as primary joint stabilizers. The acetabulofemoral joint, or hip joint, pictured here, is an example of a synovial joint. And a synovial joint is capable of a wide range of movements and consequently may be susceptible to dislocation. Some synovial joints may also contain intra-articular surfaces that help with joint function, such as the menisci of the tibiofemoral joint, otherwise known as the knee joint. So we just discussed how a synovial joint is considered a true joint, and in contrast, a fibrous joint is often considered a false joint. And this is due to the continuous connections between the articular surfaces of the bones, created by intervening fibrous tissue. And fibrous joints also exhibit low to moderate mobility. A fibrous joint can be further classified into 3 subgroups. First, we have the synarthrosis joint, which can be found between the flat bones of the skull. And the synarthrosis joint is represented in this image by the cranial sutures. The cranial sutures act as the continuous fibrous connections occupying the joint space, and the synarthrosis joint is a fairly immovable joint. Next, we have the syndesmosis joint, which is formed by the interosseous ligaments holding the 2 bones in place, and an example of this is the tibiofibular joint. And finally, we have the gomphosis joint, which can be found in the mouth, where the roots of the teeth articulate with the dental alveoli, and this is called a dental alveolar joint. And now we're going to talk about our cartilaginous joints, which, like our fibrous joints, are also called false joints. Cartilaginous joints are characterized by the continuous cartilage connection between 2 bones. And although this type of joint is classified as a false joint, it actually exhibits a moderate range of mobility, which is greater than that exhibited by fibrous joints. And there are 2 types of cartilaginous joints. The first type, known as a synchondrosis joint, or primary cartilaginous joint is where the hyaline cartilage meets with bone. For example, at the costochondral joints of the anterior thoracic cavity, we can find a synchondrosis joint between the ribs and the highlighted costal cartilage. The second type of cartilaginous joint is known as the symphysis joint, or secondary cartilaginous joint. And this type of joint is found primarily along the midline of the body and is characterized by adjacent bone surfaces lined with hyaline cartilage and connected by fibrous tissue. For example, the pubic symphysis, which is shown just here. Joints and motion. So when classifying a joint based on its range of motion, it's important to first understand the various axes that the movements are occurring along. And in joint movement, there are three main axes: the x-axis for up and down movement, the y-axis for side-to-side movement, and the z-axis, which is for three-dimensional movement. We can also describe joints by the number of axes they can move along, and there are three of these joints. Joints that can move back and forth along a single axis are called uniaxial. Joints that move about two distinct axes are called biaxial, and joints that can move through all three axes are called polyaxial or multiaxial. And as we continue, do keep these axes in mind to help you visualize the motions being described. There are 6 types of joints that are classified by their range of motion: the ball and socket joint, the hinge joint, the pivot joint, the condylar joint, the saddle joint, and the plane joint. Note that all these joints are synovial joints. The ball and socket joint, also known as the spheroidal joint, is the only polyaxial joint and therefore the most mobile of all joint types. And 2 examples of this joint are the acetabulofemoral joint, otherwise known as the hip joint, and the glenohumeral joint, or the shoulder joint, which is shown here. And using the glenohumeral joint as a reference, we can see that this ball and socket joint has one ball-shaped articular surface, the head of the humerus, and one socket-like articular surface, the glenoid cavity. The hinge joint has one axis of motion, which is along the x-axis, making it uniaxial. And of course, this results in only 2 types of movement: flexion and extension. And examples of this joint are the knee joint, or the tibiofemoral joint, shown on the left, and the elbow joint, shown on the right. And like the hinge joint, the pivot joint is also uniaxial. However, instead of movements along the x-axis, the pivot joint can perform rotational movement only along the y-axis. And the pivot joint is given its name because it acts like a pivot in a lever system. So if you can imagine how a pivot wrench works, which is by rotating a nut or a bolt around the y-axis, then you can also visualize how a pivot joint works with its up and down movements. And examples of a pivot joint are the atlantoaxial joint between the axis and atlas bones of the cervical spine, which is the joint that's on the right here, and the proximal and distal radioulnar joints, which is on the left. And this joint, with its uniaxial movements, would therefore allow you to do an action such as unscrewing the lid of a jar. The condylar joint, also known as the ellipsoid joint, is a biaxial joint that has 4 primary movements. And an example of this type of joint is the radiocarpal joint. And this joint, which is found at the wrist, permits independent radial or ulnar deviation, as well as flexion and extension of the hand. And just a note on the radiocarpal joint, the combination of these movements can give the false impression that it is a polyaxial joint. The saddle joint is another type of biaxial joint. And in this particular joint, we can see that the bones involved meet at the concave articular surface of one bone and the convex articular surface of the other. And this is the connection that forms the saddle-shaped articulation. The saddle joint allows movement along 2 axes, however not independently. And an example of such a joint is the carpometacarpal joint of the thumb, which has an inverted saddle shape. And this joint is necessary for the opposition of the thumb. And the final type of joint we're going to have a look at the body is the plane joint. And this type of joint, unlike the other joints we've discussed, only permits movement along the plane of the articular surface, and therefore it cannot be classified as a uniaxial, biaxial, or polyaxial joint. Instead, the plane joint performs what is known as a translational movement, which is where a bone of the joint slides or glides over another point of the joint. And an example of the plane joint is the acromioclavicular joint, which increases the flexibility of the shoulder.
There is way more to know about your skeletal system than just the names of the bones. In addition to bones, there's cartilage and fibrous connective tissue that allows them to work together. And maybe more importantly, if you're going to talk about the physiology of your skeleton, you have to talk about joints. Joints are the meeting places between two or more bones, and even though it might not sound mathematically possible, you actually have more joints in your body than you have bones. In a lot of places, like your hands and feet, each individual bone is part of more than one or two joints. And then there's the matter of what all that bone, cartilage, connective tissue, and the joints that they form actually work together to do. And that is move. Body movements happen when muscles contract across joints, moving one bone toward another, and studying the different types of movements your body is capable of is not only pretty fun, it's also one of the best practical ways to understand your bones and joints. Don't worry, it's not anyone you knew. It's plastic. And it's a little bit smaller than the average adult skeleton, but other than having me stand in front of a giant x-ray machine for 10 straight minutes, I can't think of a better way to walk you through the major anatomical structures of your skeleton. You'll recall that anatomists typically divide the skeleton into two major parts, the axial and the appendicular. The axial structure includes all 80 midline bones that form your skull, vertebral column, and thoracic cage. Starting at the top here, your skull's 8 cranial and 14 facial bones form your body's most complex bony structure, coming together to do some pretty great things like protect your brain, help you see, smell, hear, eat, and, have a face. The 33 irregular bones in your vertebral column start with your atlas vertebra, the one that holds up your skull and is named for the Greek god Atlas, who held the world on his shoulders as a punishment. The vertebrae run down from your skull to your pelvis, providing the central support for your upper body and completing the enormously important job of protecting your spinal cord, the main communication line between nearly all of your body and your brain. Most of your vital organs are protected by the 12 pairs of ribs and dagger-like sternum that together comprise your thoracic cage, which also provides attachment points for your back, chest, shoulder, and neck muscles. Now, the appendicular skeleton includes your upper and lower limb appendages and pectoral and pelvic girdles that attach to the axial skeleton at the shoulder and the thigh. And even though your arms and legs clearly serve different functions, unless you spend a lot of time walking around on your hands or picking stuff up with your feet, both sets of limbs share a similar setup. They're each composed of 3 major segments, a common arrangement we see in loads of animals all the way back to fish, which anatomists refer to as one bone, 2 bones, lots of bones and digits. We can't all be Dr. Seuss. And that's just about enough anatomy for this plastic skeleton to pay for itself. I'd rather focus on the physiology of the skeleton, and in order to do that, we gotta talk about joints. As is often the case in anatomy, we classify joints both by what they're made of and by what they do. Because form follows function, we can't really talk about one without talking about the other. So the structural classification of your bones is all about what kind of material binds those bones together. Like, is it a fibrous tissue or cartilage or a special fluid-filled joint cavity? But the functional classification focuses on how much that joint can move. So for example, you have joints in your body that don't move at all. These include, say, the joints between the bones that make up your cranium. These non-moving joints are called synarthroses. But you also have joints that move only slightly, like the spot where your 2 pubic bones meet to form your pelvis. That joint exists mainly to absorb shock from walking and running, but it also has proven very handy during things like childbirth. These partly moving joints are called amphiarthroses. Finally, there are the diarthroses, which are fully movable, like your classic knee and elbow joints. They're mostly found in your limbs. But if you eventually find yourself in the business of examining and treating people's joints, and there are a lot of doctors who do, then it'll be especially useful to know the structural classifications. Structurally speaking, you've got fibrous, cartilaginous, and synovial joints. Fibrous joints connect bones with dense fibrous connective tissue and are mostly immovable, like those sutures between your skull bones. As you might guess, your cartilaginous joints unite bones using cartilage and are similar to their fibrous brethren in that they don't move very much and they lack a joint cavity. But the family of joints that make all the sports and the entire art of breakdancing and yoga possible are the freely movable synovial joints. Most joints in your body fall into this category. Although they do make use of cartilage and fibrous connective tissues like ligaments, they're different in that the bones they join are separated by a fluid-filled joint cavity. The cool thing about these cavities is that they contain a bit of viscous, egg white-like synovial fluid that acts like grease on a hinge. Without that lubricant, just running down the street could cause enough friction not not only to wear out your joint surfaces, but actually overheat your joints enough to essentially cook the surrounding tissue and leave your legs smoking like a desperate Looney Tunes character. These freely movable synovial joints come in 6 different configurations that together allow pretty much any movement your body can make, from a subtle head nod to a vigorous jumping jack, all of which you will find in action at your typical dance party. Seriously though, dance parties are an excellent place to study skeletal physiology. I mean, let's just take this from my perspective. I'm at my high school prom. I'm wearing a tux that is really uncomfortable, and I'm feeling kind of shy standing on the edge of the crowd. Maybe I want to test the waters out a little bit with like a little hand dancing, just a hand going. Waving my hand from side to side. It's a type of gliding movement, one that occurs when one flat bone surface glides over another. All these motions use gliding or plane joints like the one between the distal ends of your radius and ulna and the carpal bones of your wrist. But say after a while, I feel like these gliding movements just aren't enough to fully express myself. I have to enlist the more versatile angular movements. These are the types of motion that either increase or decrease the angle between 2 bones across any plane in the body. Like if I bob my head or kick my leg up or raise the roof, if people still do that. If that bending motion decreases the angle of the joint and brings those bones together, like when I bend my arm together, that movement is called flexion. When I bend it back, I'm increasing that angle, and it's called extension. And if I continue that motion beyond my normal anatomical positioning, and it's somewhat dangerous, that is called hyperextension. These motions enlist the hinge joints. Similarly, my oval-shaped condylar knuckle joints allow my fingers to bend and ball up for a good fist pump. Now I'm getting super into it. I might like raise my arms up over my head, while the act of raising my arms away from my body is called abduction, while moving them back down toward the body is called adduction. And this here like lasso movement, that's circumduction, a combination of all 5 of those movements that allow the forearm to move in a circle while the elbow joint stays relatively stable. Which really makes you want to give credit to those cowboys. Now if you want to get really serious about that lassoing and expand it to include the entire arm, the move eventually will morph from an angular movement to a rotational one, a motion that turns the bone around its axis, in this case, the humerus. Hip and shoulder joints use a ball and socket design that allow rotational movement, but the more flexible a joint is, the more unstable and fragile it is, which is one reason why you see so many dislocated shoulders and hip replacements. And it's worth pointing out that some movements are just special and unique and weird and only occur in a few select joints, especially in your hands, feet, and jaw. For example, your ability to touch your thumb to your fingertips or give a thumbs up is thanks to opposition movement facilitated by your saddle joint, which makes your thumbs opposable. The pivot joint between your radius and ulna allow you to rotate your palm forward or anteriorly in a motion called supination, and turning it backward or posteriorly is called pronation. So that's what I like to think is the more grown-up approach to teaching you about your skeleton.
The shoulder joint, as you can see already from the images that are displaying on your screen. And what I'm going to do is talk about the most mobile joint in your body, but also the one that is most susceptible to injury. You have probably heard of someone close to you that has had some sort of shoulder dislocation. Now, what you have on the screen, on your left, you will find a posterior side of the joint, and on your right, you can find the interior view of the shoulder joint. One thing that you need to know about this joint is about the type. This is a synovial joint, a ball and socket, which, as you know, ball and socket joints have great freedom of movement. Now let's start talking also about the articulating surfaces. The articulating surfaces of the shoulder joint is the head of the humerus, the rounded head of the humerus, and also the shallow and pear-shaped glenoid cavity of the scapula. And keep in mind that both these articulating surfaces are covered by hyaline cartilage. Very important. Another characteristic about these 2 articulating surfaces is that the head of the humerus is about 3 to 4 times larger than the articular surface of the scapula or the glenoid cavity. That is why, to help correct this difference, you're going to find on the edges of the glenoid cavity a fibrocartilage rim, as I'm drawing right now. And this fibrocartilage rim is known as the glenoidal lip or the glenoid labrum or labrum. Now, it's important to know that the size of the articulating surfaces have an advantage. It allows an increased range of shoulder motion, but it also has a disadvantage, and that is that it compromises the stability of the joint. That's why there is always a lot of problems associated to it. So weak ligaments and capsule, the joint is primarily stabilized by the rotator cuff muscles and other muscles that we're going to see later on this tutorial. As you can see here on this image, I zoomed in on the anterior view of the shoulder joint, where I'm going to start talking about a very important feature known as the capsule. And the capsule of the shoulder joint is surrounding the entire joint. And medially, as I'm highlighting here in blue, medially is attached to the glenoid cavity, right outside that fibrocartilaginous extension that I talked about on the previous slide, known as the glenoid labrum. Now this capsule will extend all the way laterally, where it's then going to attach to the anatomical neck of the humerus. And then, as you can see here in this image, will extend just a little bit further down medially to the side of the shaft of the humerus for just a short distance, as you can see. The important feature of the capsule is that it's thin and broad, which then allows the wide range of movements that are associated to this joint. Also, it is partially strengthened by ligaments and also by the tendons of the rotator cuff muscles, which we are going to discuss later on this tutorial in a little bit more detail. Now, one important feature that I would like to add on the capsule is that if you notice, there is a little recess or a little bump that I'm going to highlight here in green. This is when the arm is hanging down. You see that the lower part of the joint capsule, which is not reinforced by muscle, is sagging and is forming this green structure that I highlighted. Well, it's not in green, but it's highlighted in green and is known as the axillary recess. This provides a reserve capacity that is useful during abduction movements of the arm. As you probably noticed, we're still talking about the capsule of the shoulder joint, and from previous knowledge you know that capsules on synovial joints have two main layers, the synovial layer and the fibrous layer. Both these layers have different, or they're comprised of different types of tissues, as well as their location in the capsule are different. So the synovial layer is located in the innermost part of the capsule, usually in contact with synovial fluid, hence the name synovial layer. Now the fibrous layer is usually located more externally and also have a different composition or comprised of different tissues. Now, knowing that, let's talk about the synovial layer of the capsule of the shoulder joint. This layer is actually attached to that extension that we talked about, this fibrocartilaginous extension known as the glenoid labrum. This is the attachment of the synovial layer. And also I'm going to add here the muscle of the bicep brachii muscle. As you can see, the long head, or the tendon of the long head, goes through the intertubercular sulcus on the humerus and then attaches to the supraglenoid tubercle on the scapula. And you can see that the way I highlighted that the capsule, or the synovial layer of the capsule, surrounds the tendon of the long head of the biceps and extends beyond the transverse humeral ligament. And we're going to talk about this ligament later on, but I can show you and draw you that it's connecting the two tuberosities. This is where you should find the transverse humeral ligament. Now, this extension of the synovial layer surrounding this tendon then is surrounding it as what we call the synovial sheet of the intertubercular groove, or sulcus. Now, important thing to know about the synovial layer as well is that it protrudes usually through the fibrous layer to form the bursae, which are important structures that we will talk about later that reduce friction on a joint. Now, just a quick note on the fibrous layer. All you need to know is that it forms a connective tissue layer across the intertubercular sulcus and converts it into an osteofibrous canal. So it's time to talk about the ligaments that strengthen and stabilize the shoulder joint. There are 6 that we're going to talk about on this tutorial. The first one is the glenohumeral ligament, as you can see here. This is also divided into 3 other ligaments, or 3 other weak bands of fibrous tissue: the superior, the middle, and also the inferior glenohumeral ligaments. As you can see here, this is the interior view of the joint, and for that reason you know that this ligament is strengthening the front of the capsule. And it's extending from the margin of the glenoid cavity all the way to the lesser tuberosity. Now I'm going to erase these so I can show you the 4th ligament, and this is the transverse humeral ligament, which is bridging, and we talked about on the previous slide, this is bridging the gap between the tuberosities, and it's found more laterally. The other ligament that we need to talk about is the coracohumeral ligament, which stretches from the root of the coracoid process to the greater tuberosity of the humerus, as you can see here. And this is strengthening the capsule above, or superiorly. The last ligament that we need to talk about, it's the coracoacromial ligament, as you can see here, which is connecting the acromion and the coracoid process of the scapula. This is an accessory ligament and is protecting the superior aspect of the joint. And it does so by forming an arch, as you can see here. This is forming an arch, also known as a fornix, above the joint, which is preventing superior luxation of the joint, and it restricts the movements of the joint. An example of that is abduction can only happen up to 90 degrees, because the greater tuberosity of the humerus, as you can see here on this image right here, will then come into contact with this ligament and prevent from further movement. Now it's time for us to talk about the muscles that help stabilize the shoulder joint. There are a few that we need to discuss because this joint has a few weak ligaments, so it cannot depend on them in order to be stabilized. So it is a muscle-dependent joint. So its stability depends on the muscles that are surrounding it and that are stabilizing it. The very first group of muscles that we need to discuss, that are the most relevant or that play the major role of stabilizing this joint, are known as the rotator cuff muscles. In the rotator cuff muscles, there are 4. The first one that you can see anteriorly is the subscapularis, that originates on the scapula and goes all the way to the lesser tuberosity of the humerus. So that's why you can see that is related to the joint, the shoulder joint. The other 3, you can find them on the posterior view, and these are the infraspinatus, as you can see here, and the supraspinatus, and I'm going to clear these 2 so you can see the other one, which is the teres minor. Both the infraspinatus and supraspinatus origin on the scapula and then will insert on the greater tuberosity of the humerus. And also the teres minor is originating on the scapula and goes all the way to insert as well on the greater tuberosity of the humerus. Now I want to show all of these muscles together so you can see the entire group of the rotator cuff muscles. So we still have here the muscles of the rotator cuff, so I can show you the next muscle that plays a role in stabilizing the shoulder joint, and this is the teres major muscle. I just showed you posteriorly, but I will also show you anteriorly, and this is it. And the teres major is inserting on the crest of the lesser tuberosity, and that's why it's also playing a role in stabilizing the shoulder joint. Next muscle that helps stabilize the joint is the coracobrachialis muscle, as you can see here, that originates on the coracoid process of the scapula and goes to insert in the humerus in line with the crest of the lesser tuberosity. That's why it's helping stabilize this joint. The next muscle that helps stabilize the shoulder joint is a very powerful one known as the deltoid muscle, as you can see here on the posterior view, and it's better to show it on this side so you can see it in its majority. And you can see that this muscle is originating from the scapula and the clavicle, and I also have another image here that illustrates a little bit better where it's going to insert. And it will insert in the very well-known deltoid tuberosity on the humerus, and that's why this muscle plays a major role not only in stabilizing the shoulder joint, but also in a lot of the movements related to this joint. The biceps brachii muscle, as I'm showing here on the image, also influences in stabilizing the joint. As you can see here, the long head, or the tendon of the long head, passes through the intertubercular sulcus on the humerus and goes and originates, if you notice here, on the supraglenoid tubercle on the scapula. So for that matter, all the movements related to this muscle will then influence or be associated to the movements of the shoulder joint, and of course this muscle also plays a role in stabilizing it. Now I'm going to talk about the last two muscles that influence in stabilizing the shoulder joint, and the one that you're seeing here right now is a portion of the latissimus dorsi, and you can see that is inserting on the crest of the lesser tuberosity on the humerus, as you can see here. Now the other one is a very powerful muscle known as the pectoralis major, and you can see that the pectoralis major is inserting here on the crest of the greater tuberosity of the humerus. The next topic on this shoulder joint tutorial is going to be the bursae. Bursae is plural and bursa is singular, and a bursa is a synovial sac that is filled with fluid that help cushion and also alleviate some friction that is usually associated to synovial joints. Very, very important structures. Now, remember from a previous topic when we talked about the synovial layer and also the fibrous layer of the capsule? Well, the synovial layer usually protrudes through the fibrous layer, and that way it will form some bursae. Now in this tutorial I'm going to talk about 4 bursae, and the first one you can see on this image. We're looking at it anteriorly, and I left some of the ligaments so you can see where you can find this bursa in relation to these structures. Now the first one is known as the subacromial and subdeltoid bursa, this green structure that you find here. And you can see it here also posteriorly and a little bit more superiorly. You find also this subacromial, this green structure here. This is the subacromial and subdeltoid bursa. Now there are 3 other bursae that I need to cover here on this tutorial. What I'm going to do now is highlight the capsule and also the bursae associated to the capsule and to the joint so you can see where they are located. Now the first one is this red, highlighted in red, and this is the subcoracoid bursa. The next one is this one highlighted in blue, and this is the subtendinous bursa of the subscapularis muscle. So this is just beneath the tendon of the subscapularis muscle. And the next one, this yellow structure here, is known as the intertubercular synovial sac. So this is surrounding the tendon of the long head of the biceps, and you can see it a little bit better on this image here. So I'm going to also highlight it in yellow, so you can see that this structure, this intertubercular synovial sac or sheet, is surrounding the tendon of the long head of the biceps and is extending beyond the transverse humeral ligament that you can see better on this image. Here is the transverse humeral ligament, and that way it's surrounding the tendon as the synovial sheet of the intertubercular sulcus or groove. Now it is time for us to talk about the blood supply of the shoulder joint. There are a few vessels that we need to discuss. The first one is the anterior. This is on the anterior side, and it's highlighted in blue here. This small artery here is known as the anterior circumflex humeral artery, and it originates from the axillary artery right here. And the other one that is also supplying the shoulder joint is on the posterior side, and this is the posterior circumflex humeral artery, highlighted in green. Now the other one that is also a major blood supplier of the shoulder joint is this one here, this small vessel here, highlighted in yellow. This is the suprascapular artery, and it originates from the subclavian artery. The shoulder joint also has a nerve supply, and I wanted to briefly discuss here on this tutorial. And what you have here is 2 views, the anterior or posterior view, on your left, and the anterior view here on your right. And the first nerve that we're going to discuss is the axillary nerve. And I have it here highlighted in green. As you can see, this is this structure that is passing through all or alongside these structures that I left so you can have an idea of the relation of the axillary nerve to the other structures on the shoulder joint. And on the anterior view, you can also see highlighted in green the axillary nerve that comes off the brachial plexus from the upper trunk, posterior division, and posterior cord. But I don't want to go into details. I will do a tutorial on the brachial plexus later on. But this is just to know that the axillary nerve also carries fibers from C5 and C6. The next structure, the next nerve that we will talk about, this is the second one and the last one that I want to cover on this tutorial, is the suprascapular nerve, and you have 2 posterior views, so you can see the suprascapular nerve also highlighted in green. You can see it also on your right and with more structures involved, so you can see how it relates to them. And this suprascapular nerve arises from the upper trunk and is formed by the union of the 5th and 6th cervical nerves or fibers. Now for the last part of this tutorial, I want to briefly discuss the movements associated to the shoulder joint. And as I mentioned before, this is one of the most mobile joints that you have in your body. As you're watching now this tutorial, I suggest you move your shoulder as much as you want, or move your arm as much as you want. That's thanks to this very mobile joint. Now, the movements that we're just going to briefly touch are the abduction and adduction. As you're seeing the arrows, this is where the movement will occur. Now the other 2 are flexion, which is forward lifting of the arm, and extension, which we would say it's backward lifting of the arm. Now you also have internal or medial rotation and external or lateral rotation. You do have elevation, which is excessive associated scapular movement, which will happen with abduction of more than 90 degrees. Say if you're lifting your arm high enough to hail a cab or a taxi, and this happens because we call it excessive, let's say, because the joint movement is restricted by the coracoacromial ligament that you have here. So it's restricted by this ligament right here. Now the last movement that we're going to talk about is known as circumduction, and this is a combination of movements such as flexion, extension, and abduction and adduction. The elbow joint. Now I'm going to simplify or try to simplify this joint to you because it's quite tricky to learn. And for that reason, the very first thing that you have to understand is that the elbow joint is happening between three bones, three main bones, as you noticed here on this image as well. Now the first one is this large bone here known as the humerus. And then you have this one located laterally, and this is the radius. And the third bone is this one located medially. This is the ulna. So these are the three bones that comprise the elbow joint, or that are in the elbow joint. Now, important thing to know is that also the elbow joint is a synovial hinge joint, and it is a compound joint. What is a compound joint? A compound joint is simply a joint that is comprised of other joints, other sub-joints. I use this term loosely, but other sub-joints. And the sub-joints, let's say, that belong to the elbow joint or are in the elbow joint are the humeroradial joint. And as the name indicates, this is the joint occurring between the humerus, more specifically the capitulum of the humerus, and the head of the radius. So this is the humeroradial joint. Now the other one is, of course, the humero-ulnar joint. And this is also happening, as the name indicates, with the trochlea of the humerus, the structure right here that I'm showing to you, and then, of course, the trochlear notch of the ulna. Now there is another joint that belongs, the third joint that belongs to the elbow joint, and this is known as the proximal radio-ulnar joint. And this is a joint or an articulation that is occurring between the circumference or the articular circumference of the head of the radius, as you can see here, and then the radial notch of the ulna right here. So this is the proximal radio-ulnar joint. You also find another one a little bit more distally known as the distal radio-ulnar joint, also occurring between the radius and the ulna. Now, knowing that, another point that I want to add here on the articular surfaces of the elbow joint, of all these three joints that belong to the elbow joint, is that they're all covered, or the articular surfaces are all covered, as you can see here on this image, this lighter or grayish color. It's representing hyaline cartilage. So all the articular surfaces of the elbow joint are covered by hyaline cartilage. Now we're going to talk about the capsule of the elbow joint, and I'm going to show you right now. So this is the capsule, and the capsule also has an outline and is attaching to several structures on each bone that we talked about. So as you see on this outline here above or proximally, the capsule is attaching to the margins or along the margins of the coronoid and also the radial foci. And I can just show you by removing the capsule that these are the margins of Here, this is the radial fossa, and here is the margin of the coronoid fossa on the humerus. Now, if I put it back, you can also see that the capsule is attaching to both the lateral epicondyle and also the medial epicondyle of the humerus. But keep in mind that both epicondyles are exposed, as you can see here. So they're not contained within this capsule that we're talking about. Now, a little bit more distally, or a little bit below here, you notice that the capsule is attached to the margin of the coronoid process here on the ulna. And it is attached on the radial side too, on the lateral side, to a ligament that we're going to talk about, and I'm showing you right now. So I just added this image of this ligament known as the annular ligament, and the capsule is definitely attaching to this ligament as well here on the lateral side. Now we're still talking about the capsule of the elbow joint, but this time we're looking at it on the posterior side, or the back view of the elbow joint. And I just have here an outline in green of where the joint should be, or the capsule of the joint should be. So as you notice here, that on the proximal side, or this upper view here, that it is attached to the margins of the olecranon fossa of the humerus. Now, if we go a little bit more distally, you notice here that is also attached to other margins, but this time of the olecranon process of the ulna. Also a little bit more distally, and you notice here as I'm pointing it right now, this should be an attachment that will happen on the annular ligament that I just showed you before. So this is the posterior view of the capsule of the elbow joint. Now, as I mentioned before, I told you that the elbow joint is a synovial hinge joint, and synovial means that this joint will have space, or there will be space between the articulating surfaces. And for that reason, you will find then what we're going to talk about right now, the synovial membrane. So there is a synovial membrane, and I'm showing you right now the outline of this synovial membrane that is clearly lining the capsule of the elbow joint, as you can see here. So this synovial membrane is lining the capsule. And also a couple things that I'm going to add here that you find on this synovial membrane is that it covers fatty pads in the coronoid, the radial, and also the olecranon fossae. And also you can notice that it goes a little bit beyond, or continuously below, the synovial membrane of that other subjoint that I talked about, the proximal radio-ulnar joint. Now we're going to talk about very important structures that help stabilize the elbow joint, and these are the ligaments. And there are 3 ligaments that we need to briefly go over and talk about on this tutorial. The first one I already discussed and mentioned a little bit about it. This was then the annular ligament. And as you can see here, the annular ligament is surrounding the head of the radius and attaches on the ulna on both sides. Now, the other two, there are 2 very important ligaments known as collateral ligaments. They're very, very strong. They're main stabilizers of the elbow joint. And the first one that I'm going to show you right now, this is known as the ulnar collateral ligament, or you can also call it the medial collateral or the medial ligament. We're going to discuss a little bit more in detail on the next slide, but for now you can see here it highlighted in blue that this is the ulnar collateral ligament. Now the other one is then going to be the radial collateral ligament, here highlighted in yellow, and this is another very strong ligament. Now, I wanted to talk a little bit more about the collateral ligaments, and let's start then with the radial collateral ligament, this yellow structure here. And what I want to say is this is a triangular shaped ligament. You cannot see very well on this image here, but you can see enough for me to tell you that this is attaching to the tip as you notice here, of the lateral epicondyle of the humerus. Then goes all the way, if you follow, this is all the way to the upper margin of this red ligament that we just talked about, the annular ligament. Now, a few words on the ulnar collateral ligament, this structure here highlighted in blue. As you notice here, the ulnar collateral ligament has a slightly triangular shape that you can notice here on this image. And it is comprised of three very, very strong bends. And in order for us to understand how they look and how they are in comparison to one another and how they're attached, we're going to use a very, very simple image here that sometimes we have to rely on whenever we're studying anatomy. We have to simplify things and make it a little bit more clearer. So this image here is showing, as you can see, the triangular shaped ulnar collateral ligament. And the three different bends are, of course, in different colors, in different blue colors. Now here you have the humerus and, of course, the ulna. Let me tell you that you're having a medial view here. So you're looking at it as if you were looking in this direction. So this image here on your left is the anterior view. And now you're looking at the collateral ligament, the ulnar collateral ligament on a medial side, medial view. And you would see, of course, this clear triangular shape that the ligament has. Now, the first bend that you can notice here is located a little bit on the anterior side, and of course you would call it then the anterior bend. And as you can see, it's attaching from the medial epicondyle to the medial margin of the coronoid process of the ulna. Now you see another bend here in a darker blue, and this bend is then the posterior bend. And the posterior bend is attaching from also the medial epicondyle of the humerus right here, and goes all the way to attach on the side, or on the medial side of the olecranon of the ulna. Now the third bend is this one right here, another blue, and this is known as the transverse bend. And as you can see, this transverse bend is connecting, in a way, the two other bends that we talked about. So this transverse bend is between the ulnar attachments of the two other bends that we talked about. Now, in the last part of this tutorial, I'm just going to briefly mention a couple of words on nerve supply of the elbow joint. And I can tell you that there will be 4 main nerves that also support or supply the arm and the forearm. And branches of these nerves will then supply the structures found on the elbow joint. Now, the first one that you need to know is definitely the median nerve. Also, branches of the ulnar nerve and the radial nerve will be supplying the elbow joint. And finally, the fourth nerve that will be supplying this joint is going to be the musculocutaneous nerve. All these 4 nerves have branches that will then supply the elbow joint.
Few structures of the human anatomy are as unique as the hand. The hand needs to be mobile in order to position the fingers and thumb. The hand must have adequate strength to grip objects firmly, but must also be coordinated to perform fine motor tasks with precision. The important structures of the hand can be divided into several categories. These include bones, joints, ligaments, tendons, muscles, nerves, and blood vessels. Let's define some common anatomic terms as they relate to the hand. This will make it clearer as we talk about the structures of the hand later. The front or palm side of the hand is referred to as the palmar side. The back of the hand is called the dorsal side. The half of the hand from the middle finger to the thumb is called the radial side. The other half is called the ulnar side. There are 27 bones within the wrist and hand. The wrist itself contains 8 small bones called carpals. The carpals join with the two forearm bones, the radius and ulna, forming the wrist joint. Further into the palm, the carpals connect to the metacarpals. There are 5 metacarpals forming the palm of the hand. One metacarpal connects to each finger and thumb. Small bone shafts called phalanges line up to form each finger and thumb. The main knuckle joints are formed by the connections of the phalanges to the metacarpals. These joints are called the metacarpophalangeal joints, or MCP joints. The MCP joints work like a hinge when you bend and straighten your fingers and thumb. The 3 phalanges at each finger are separated by 2 joints, called interphalangeal joints, or IP joints. The one closest to the MCP joint is called the proximal IP joint, or the PIP joint. The joint near the end of the finger is called the distal IP joint, or DIP joint. The thumb only has one IP joint between the 2 thumb phalanges. The IP joints of the digits also work like hinges when you bend and straighten your fingers and thumb. The joints of the hand, fingers, and thumb are covered on the ends with articular cartilage. This white shiny material has a rubbery consistency. The function of articular cartilage is to absorb shock and provide an extremely smooth surface to facilitate motion. There is articular cartilage essentially everywhere that 2 bony surfaces move against one another or articulate. Ligaments are tough bands of tissue that connect bones together. 2 important structures called collateral ligaments are found on either side of each finger and thumb joint. The function of the collateral ligaments is to prevent abnormal sideways bending of each joint. In the PIP joint, the middle joint between the main knuckle and the DIP joint, the strongest ligament is the volar plate. This ligament connects the proximal phalanx to the middle phalanx on the palmar side of the joint. The ligament tightens as the joint is straightened and keeps the PIP joint from bending back too far or hyperextending. Finger deformities can occur when the volar plate loosens from disease or injury. Many of the muscles that control the hand start at the elbow or forearm. They run down the forearm and cross the wrist and hand. Some control only the bending or straightening of the wrist. Others influence motion of the fingers or thumb. Many of these muscles help position and hold the wrist and hand while the thumb and fingers grip or perform fine motor actions. Most of the small muscles that work the thumb and little finger start on the carpal bones. The bulge of muscle at the base of the thumb in the palm is called the thenar eminence. The bulge of muscle at the base of the little finger is called the hypothenar eminence. 4 muscles make up the thenar eminence: the abductor pollicis brevis, flexor pollicis brevis, adductor pollicis, and opponens pollicis. Pollicis is the Latin term for thumb. Each of these muscles begins at the wrist, and each has a tendon that attaches to a different location on the base of the proximal phalanx of the thumb. Their names give a suggestion of what they do when they contract. The abductor pollicis brevis abducts or moves the thumb away from the midline of the hand. The flexor pollicis brevis flexes or bends the thumb. The adductor pollicis adducts or moves the thumb towards the midline of the hand. The opponens pollicis moves the thumb into opposition. It pulls the thumb out from the palm and turns the pulp of the thumb to face the palm. This is the motion that allows you to place the tip of your thumb against the tip of your little finger. The muscles of the hypothenar eminence are arranged and function roughly the same in the little finger. The smallest muscles that originate in the wrist and hand are called the intrinsic muscles. The intrinsic muscles guide the fine motions of the fingers by getting the fingers positioned and holding them steady during hand activities. The tendons that allow each finger joint to straighten are called the extensor tendons. The extensor tendons of the fingers begin as muscles that arise from the backside of the forearm bones. These muscles travel towards the hand, where they eventually connect to the extensor tendons before crossing over the back of the wrist joint. As they travel into the fingers, the extensor tendons become the extensor hood. The extensor hood flattens out to cover the top of the finger and sends out branches on each side that connect to the bones in the middle and end of the finger. The place where the extensor tendon attaches to the middle phalanx is called the central slip. When the extensor muscles contract, they tug on the extensor tendon and straighten the finger. Problems occur when the central slip is damaged, as can happen with a tear. The flexor tendons allow the fingers and thumb to flex or bend to grip objects in the palm of the hand. The strong flexor muscles begin in the forearm, and just before they enter the wrist, the flexor muscles form the flexor tendons. The flexor tendons travel through the carpal tunnel, through the palm, and two tendons each travel into the volar side of each finger. These two tendons, the flexor superficialis and flexor profundus, travel through a special tunnel formed by a series of specialized ligaments that form pulleys. The flexor superficialis connects to the base of the middle phalanx. The flexor profundus tendon connects to the base of the distal phalanx. The thumb is a bit different since it only has two phalanges. The flexor pollicis longus begins in the forearm, and its tendon connects to the base of the distal phalanx of the thumb. The flexor pollicis brevis muscle begins in the wrist, and its tendon connects to the base of the proximal phalanx of the thumb. All of the nerves that travel to the hand and fingers begin together at the shoulder. The radial nerve, the median nerve, and the ulnar nerve. These nerves carry signals from the brain to the muscles that move the arm, hand, fingers, and thumb. The nerves also carry signals back to the brain about sensations such as touch, pain, and temperature. The radial nerve runs along the thumb side edge of the forearm. It wraps around the end of the radius bone toward the back of the hand. It gives sensation to the back of the hand from the thumb to the third finger. It also supplies the back of the thumb and just beyond the main knuckle of the back surface of the ring and middle fingers. The median nerve travels through a tunnel within the wrist called the carpal tunnel. This nerve gives sensation to the thumb, index finger, long finger, and half of the ring finger. It also sends a nerve branch to control the thenar muscles of the thumb. The thenar muscles help move the thumb and let you touch the pad of your thumb to the tips of each finger on the same hand, a motion called opposition. The ulnar nerve travels through a separate tunnel called Guillaume's canal. This tunnel is formed by two carpal bones, the pisiform and hamate, and the ligament that connects them. After passing through the canal, the ulnar nerve branches out to supply feeling to the little finger and half the ring finger. Branches of this nerve also supply the small muscles in the palm and the muscle that pulls the thumb toward the palm. Each finger has a pair of sensory nerves, one on each side, that runs to the tip of the finger. These nerves are called the digital nerves and supply sensation to the fingers. Traveling along with the nerves are the large vessels that supply the hand with blood. The largest artery is the radial artery that travels across the front of the wrist closest to the thumb. The radial artery is where the pulse is taken in the wrist. The ulnar artery runs next to the ulnar nerve through Guillaume's canal, which has been mentioned earlier. The ulnar and radial arteries arch together within the palm of the hand, supplying the front of the hand, fingers, and thumb. Other arteries travel across the back of the wrist to supply the back of the hand, fingers, and thumb. When our hands are free of problems, it's easy to take the complex anatomy of the hand for granted. The hand is formed by numerous structures. Each has an important role in the normal hand function. Injuries and conditions that change the way these structures work can greatly impact whether the hand functions normally.
So the hip joint is a ball and socket synovial joint, forming the connection between the lower limb and the pelvic girdle. And as we can see in this image, we have the pelvis here and the right femur just here. And the hip joint is also multi-axial, meaning that it rotates on more than one axis, which allows for a wider range of movement. And of course, the hip joint is designed for stability and weight bearing. So as we can see in this image, the head of the femur articulates with the lunate surface of the acetabulum of the pelvis. The lunate surface is concave, which is like the shape of a crescent moon, as the name lunate suggests. And the hip joint can therefore also be referred to as the acetabulofemoral joint. Now, both the lunate surface of the acetabulum and the head of the femur are covered by hyaline cartilage, with the exception of the fovea capitis femoris, which we'll talk a little bit about later. And of course, hyaline cartilage is a simple cartilage found on many articulating surfaces. So the acetabulum is the part of the pelvis where the ilium, ischium and pubis bones merge. And as we've mentioned before, it's concave and almost entirely encompasses the head of the femur, which of course contributes to the stability of the joint. And we've already mentioned the lunate surface of the acetabulum, which is covered by hyaline cartilage. So as we can see in this image, at the center of the acetabulum is a non-articulating surface, which is known as the acetabular fossa, just here. And this part of the acetabulum contains loose connective tissue, a mobile fat pad, and is not covered by hyaline cartilage. The acetabular labrum is the fibrocartilaginous collar or lip that surrounds the bony rim of the acetabulum. And as we can see, it bridges across the acetabular notch, just here, as the transverse acetabular ligament. And the labrum of the acetabulum increases the stability of the hip joint by deepening the acetabulum and increasing the area of articulation with the head of the femur. So as we can see in this image, the ball of the ball and socket hip joint is the rounded head of the femur, which sits within the concavity of the acetabulum, which is our socket of the joint. And the head of the femur is entirely covered by hyaline cartilage except for an area called the fovea capitis femoris, which we've talked about briefly before. This is where the ligament of the head of the femur connects the femur at the fovea to the acetabular fossa, the transverse acetabular ligament, and the margins of the acetabular notch. And now let's just point out some of these structures in this image. So we have the fovea capitis sticking out here. This is, as we've mentioned, the ligament of the head of the femur. And we have the acetabular fossa here, the transverse acetabular ligament running across here, and the acetabular notch margins, which are just here. So now we're going to move on to talk about the joint capsule, which we can see in this image, covering the head of the femur and the acetabulum. So the joint capsule of the hip joint attaches to the acetabular labrum and the transverse acetabular ligament proximally, which we can't see in this image but is underneath the fibrous capsule just here, while attaching to the intertrochanteric line of the femur, which is shown in green distally. And as it has to be, it is a strong fibrous capsule that can accommodate a wide range of movements. And the capsule is strengthened and reinforced by the help of 3 ligaments, anteriorly and superiorly by the iliofemoral ligament, which connects the anterior-inferior iliac spine and the acetabular rim to the femoral intertrochanteric line, and the iliofemoral ligament is the strongest of the hip joint ligaments. Inferiorly and anteriorly, the pubofemoral ligament arises from the obturator crest and the superior ramus of the pubis and blends with the capsule and the medial part of the iliofemoral ligament. And posteriorly, the ischiofemoral ligament, seen here from a posterior view, connects the ischial part of the acetabular rim to the neck of the femur. And as we can see, the fibers from these 3 ligaments are arranged in a spiral fashion around the hip joint, which helps stabilize the joint by pulling the head of the femur medially into the acetabulum. This reduces the amount of muscle energy required to maintain a standing position, and it prevents the hyperextension of the hip as well as excessive abduction. So now let's talk about the range of movements in the hip joint. So the range of hip movements in the hip joint include flexion, movement of the leg forward, extension, movement of the leg backward, Abduction, movement of the leg laterally, away from the midline of the body. Adduction, movement of the leg medially towards the midline of the body. Medial rotation, internal rotation of the thigh towards the midline of the body. Lateral rotation, outward rotation of the thigh from the midline of the body. And circumduction, conical, precise 360-degree movement of the leg. And blood is supplied to the hip joint primarily by the medial and lateral circumflex femoral arteries, the medial shown on the left and the lateral shown on the right, and both of these arise from the deep femoral artery, and also by the artery to the head of the femur, which runs within the ligament of the head of the femur, which is shown in green, and the artery to the head of the femur is a branch of the obturator artery. And innervation of the hip joint comes anteriorly from the femoral nerve, inferiorly from an articular branch of the anterior division of the obturator nerve, posterior-superiorly from the superior gluteal nerve, and laterally from the articular branch of the sciatic nerve.
A well-functioning knee joint is critical to mobility, including standing, walking, and running. To better understand how knee problems occur, it is important to understand some of the anatomy of the knee joint and how the parts of the knee work together to maintain normal function. The important structures of the knee can be divided into several categories. These include bones, joints, ligaments, tendons, muscles, nerves, and blood vessels. First, let's define some common anatomic terms as they relate to the knee. This will make it clearer as we talk about the structures later. Many parts of the body have duplicates, so it is common to describe parts of the body using terms that define where the part is in relation to an imaginary line drawn through the middle of the body. For example, medial means closer to the midline, so the medial side of the knee is the side that is closest to the other knee. The lateral side of the knee is the side that is away from the other knee. Structures on the medial side usually have medial as part of their name, such as the medial meniscus. The term anterior refers to the front of the knee, while the term posterior refers to the back of the knee. So the anterior cruciate ligament is in front of the posterior cruciate ligament. The knee is the joint where the femur and the tibia meet. The patella, or kneecap as it is commonly called, is made of bone and sits in front of the knee. The knee joint is a synovial joint. Synovial joints are enclosed by a ligament capsule and contain a fluid called synovial fluid that lubricates the joint. The end of the femur joins the top of the tibia to create the knee joint. Two round knobs called femoral condyles are found on the end of the femur. These condyles rest on the top surface of the tibia. This surface is called the tibial plateau. The outside half, the farthest away from the other knee, is called the lateral tibial plateau, and the inside half, closest to the other knee, is called the medial tibial plateau. The patella glides through a special groove formed by the two femoral condyles called the patellofemoral groove. The smaller bone of the lower leg, the fibula, never really enters the knee joint. It does have a small joint that connects it to the side of the tibia. This joint normally moves very little. Articular cartilage is the material that covers the ends of the bones of any joint. This material is about 1/4 of an inch thick in most large joints. It is white and shiny with a rubbery consistency. Articular cartilage is a slippery substance that allows the surfaces to slide against one another without damage to either surface. The function of articular cartilage is to absorb shock and provide an extremely smooth surface to facilitate motion. We have articular cartilage essentially everywhere that two bony surfaces move against one another or articulate. In the knee, articular cartilage covers the ends of the femur, the top of the tibia, and the back of the patella. Ligaments are tough bands of tissue that connect the ends of bones together. Two important ligaments are found on either side of the knee joint. They are the medial collateral ligament, or MCL, and the lateral collateral ligament, or LCL. Inside the knee joint, two other important ligaments stretch between the femur and the tibia. the anterior cruciate ligament, or ACL, in front, and the posterior cruciate ligament, or PCL, in the back. The MCL and the LCL prevent the knee from moving too far in the side-to-side direction. The ACL and the PCL control the front-to-back motion of the knee joint. The ACL keeps the tibia from sliding too far forward in relation to the femur. The PCL keeps the tibia from sliding too far backward in relation to the femur. Working together, the two cruciate ligaments control the back and forth motion of the knee. The ligaments, all taken together, are the most important structures controlling the stability of the knee. Two special types of ligaments, called menisci, sit between the femur and the tibia. These structures are sometimes referred to as the cartilages of the knee. But the menisci differ from the articular cartilage that covers the surface of the joint. The two menisci of the knee are important for two reasons. One, they work like a gasket to spread the force from the weight of the body over a larger area. And two, they help the ligaments with stability of the knee. Imagine the knee as a ball resting on a flat plate. The ball is the condyles of the femur, and the plate is the tibial plateau. The menisci actually wrap around the round condyles to fill the space between it and the flat tibial plateau. The menisci act like a gasket, helping to distribute the weight from the femur to the tibia. Without the menisci, any weight on the femur will be concentrated to one point on the tibia. But with the menisci, weight is spread out across the tibial surface. Weight distribution by the menisci is important because it protects the articular cartilage on the ends of the bones from excessive forces. Without the menisci, the concentration of force into a small area on the articular cartilage can damage the surface, leading to degeneration over time. In addition to protecting the articular cartilage, the menisci help the ligaments with stability of the knee. The menisci make the knee joint more stable by acting like a wedge set against the bottom of a car tire. The menisci are thicker around the outside, and this thickness helps keep the round femur from rolling on the flat tibia. The menisci convert the tibial surface into a shallow socket. The socket is more stable and more efficient at transmitting the weight from the upper body than a round ball on a flat plate. The menisci enhance the stability of the knee and protect the articular cartilage from excessive concentration of force. Taken all together, the ligaments of the knee are the most important structures that stabilize the joint. Remember, ligaments connect bones to bones. Without strong, tight ligaments to connect the femur to the tibia, the knee joint would be too loose. Unlike other joints in the body, the knee joint lacks a stable bony configuration. The hip joint, for example, is a ball that sits inside a deep socket. The ankle joint has a shape similar to a mortise and tenon, a way of joining wood used by craftsmen for centuries. Tendons are similar to ligaments, except that tendons attach muscles to bones. The quadriceps tendon connects the large quadriceps muscle of the thigh to the patella. This tendon continues across the patella, or kneecap, and blends into the patellar tendon. The patellar tendon connects the patella to the tibia. The hamstring muscles on the back of the thigh also have tendons that attach in different places around the knee joint. These tendons are sometimes used as tendon grafts to replace torn ligaments in the knee joint. The extensor mechanism is the motor that drives the knee joint and allows us to walk. It sits in front of the knee joint and is made up of the patella, the patellar tendon, the quadriceps tendon, and the quadriceps muscles. The four quadriceps muscles in front of the thigh are the muscles that attach to the quadriceps tendon. When these muscles contract, they straighten the knee joint, such as when you get up from a squatting position. The way in which the kneecap fits into the patellofemoral groove on the front of the femur and slides as the knee bends can affect the overall function of the knee. The patella works like a fulcrum, increasing the force exerted by the quadriceps muscles as the knee straightens. The hamstring muscles are the large muscles in the back of the thigh. When these muscles contract, the knee bends. The most important nerves around the knee are the tibial nerve and the common peroneal nerve in the back of the knee. These two nerves travel to the lower leg and foot, supplying sensation and muscle control. The large sciatic nerve splits just above the knee to form the tibial nerve and the common peroneal nerve. The tibial nerve continues down the back of the leg, while the common peroneal nerve travels around the outside of the knee and down the front of the leg to the foot. Both of these nerves can be damaged by injuries around the knee. The major blood vessels around the knee travel with the tibial nerve down the back of the leg. The popliteal artery and the popliteal vein are the largest blood supply to the leg and foot. If the popliteal artery is damaged beyond repair, it is very likely the leg will not be able to survive. The popliteal artery carries blood to the leg and foot. The popliteal vein carries blood back to the heart. The knee has a somewhat unstable design, yet it must support the body's full weight when standing and much more than that during walking or running. So it's not surprising that knee problems are a fairly common complaint among people of all ages. The important structures of the ankle include bones, joints, ligaments, tendons, muscles, nerves, and blood vessels. The top of the foot is referred to as the dorsal surface. The sole of the foot is the plantar surface. The outside of the ankle is referred to as the lateral side. The bony bump on the lateral side is called the lateral malleolus. The inside of the ankle is referred to as the medial side. The bony bump on the medial side is called the medial malleolus. The ankle joint is formed by the connection of three bones, the talus, the tibia, and the fibula. The top of the talus fits inside a socket that is formed by the lower ends of the tibia and the fibula. The bottom of the talus sits on the calcaneus, the bone that makes up the heel. The talus works like a hinge inside the ankle socket to allow your foot to move up, called dorsiflexion, and down, called plantar flexion. The ankle socket is sometimes referred to as the mortise of the ankle, because the structure of the ankle joint is similar to a joint used in woodworking called a mortise and tenon joint. It has been used by craftsmen for centuries to create strong, sturdy connections in furniture and buildings. Inside the ankle joint, the bones are covered with a slick material called articular cartilage. Articular cartilage is the material that allows the bones to move smoothly against one another in the joints of the body. The cartilage lining is about 1/4 of an inch thick in most joints that carry body weight, such as the ankle, hip, or knee. It is soft enough to allow for shock absorption, but tough enough to last a lifetime, as long as it is not injured. Ligaments and tendons are soft tissues that attach bones to other bones and muscles to bones. The difference between ligaments and tendons is that ligaments attach bones to other bones and tendons attach muscles to bones. Both of these structures are made up of small fibers of a material called collagen. The collagen fibers are bundled together to form a rope-like structure. Ligaments and tendons come in many different sizes and shapes. The thickness of a ligament or tendon determines its strength. Ligaments on both sides of the ankle joint help hold the bones together and stabilize the ankle. 3 ligaments make up the lateral ligament complex. These include the anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. A group of ligaments, together called the deltoid ligament, support the medial side of the ankle. Ligaments are also important in connecting the distal tibia and distal fibula at the lower end of the leg where it forms the ankle mortise. This connection and the collection of ligaments that support it are called the ankle syndesmosis. 3 main ligaments form the syndesmosis. The anterior inferior tibiofibular ligament connects the tibia to the fibula and crosses above the front of the ankle. The posterior fibular ligaments connect the tibia and fibula behind the ankle joint. These ligaments include the posterior inferior tibiofibular ligament and the transverse ligament. The interosseous ligament lies immediately between the tibia and fibula. Interosseous means between bones. The interosseous ligament is a long sheet of connective tissue that connects the entire length of the tibia and fibula, from the knee to the ankle. The ligaments that surround the ankle joint help form part of the joint capsule. The joint capsule is a watertight sac that forms around all joints. It is made up of the ligaments around the joint and the soft tissues between the ligaments that fill in the gaps and form the sac. Several muscles and tendons are important for ankle joint function. The large Achilles tendon is the most important tendon for walking, running, and jumping. It attaches the two calf muscles, the gastrocnemius and the soleus, to the calcaneus and allows us to raise up on our toes. The posterior tibial tendon attaches the posterior tibialis muscle in the calf to the underside of the foot. This tendon helps support the arch and allows us to turn the foot inward. The anterior tibial tendon attaches the anterior tibialis muscle to the foot and allows us to raise the foot. The two peroneal tendons run behind the lateral malleolus and help turn the foot down and out. These two muscles and their tendons are called the peroneus longus and the peroneus brevis. As you might guess by the name, the peroneus brevis is the shorter of the two and attaches to the base of the fifth metatarsal, while the peroneus longus runs further before attaching under the foot. The nerve supply of the ankle is from nerves that pass by the ankle on their way into the foot. The large posterior tibial nerve runs behind the medial malleolus and into the foot to control the muscles in the sole of the foot. The deep peroneal nerve crosses in front of the ankle on its way to the top of the foot. Multiple branches of the superficial peroneal nerve cross along the outer edge of the ankle. The nerves on the front and outer edge of the ankle control the muscles in this area, and they give sensation to the top and outside edge of the foot. The ankle gets blood supply from nearby arteries that pass by the ankle on their way to the foot. There are two main arteries that cross the ankle. The dorsalis pedis artery runs in front of the ankle to the top of the foot. You can feel the pulse where this artery runs in the middle of the top of the foot. Another large artery, called the posterior tibial artery, runs behind the medial malleolus. It sends smaller blood vessels to the inside edge of the ankle joint. You can feel the pulse where this artery runs behind the medial malleolus. So now you have a basic understanding of the important parts of the ankle.